In today's video, we're going to be going over nurse to physician communication. So you're a nurse working on night shifts, something has happened with your patient, and you have to call the doctor for the first time. You're shaking in your boots and you don't know what to do. This video is for you. But before I get started, guys, please like and subscribe and hit the notification tool. So in my practice and in so many nurses' practices, they are using ISBARR or ISBARR, ISBARR. And this is a communication framework that you can use when you have to communicate clinical information about your patient. So it stands for identify, situation, background, assessment, recommendation, and repeat. ISBARR. So you can use this framework. It will help to paint a clear and concise picture about the patient and what's going on, and it will just foster a more open line of communication between you and that physician and will promote a positive patient outcome and patient safety as well. So let's get into it. The I stands for identify. So you want to identify who are you, where are you calling from, and what is the patient's name. And what is the patient? Who's the patient that you're calling about? Situation. What has made you pick up the phone and call this provider in the middle of the night? What is going on? What has happened? That's what you would include second. Thirdly, you would speak on the background of this patient. What is any relevant medical history that is relevant to the situation at hand? Make sure that you're always keeping in mind that everything that you're speaking about on this call should tie back to the situation. So when you're giving a background, you're not going to be including that patient was born here or patient has a dog, this, that. You're only going to be including pertinent clinical information. So, if patient had a fall, you're going to include that the patient had a hip replacement 2 years ago. That is pertinent information. You're also going to be including when, if you're in a hospital setting, when did this patient come? For how long have they been here? Are there any relevant treatments that you need to speak on? Any relevant medications that they're taking? And any allergies? You would also want to include allergies in this section. And then we're moving on to assessment. This is where you would speak on what you are observing. What is your assessment? What have you seen with your own two eyes? What are the patient's vitals? What are they saying? What are they complaining of? Have you done a head-to-toe assessment? This is what you would speak on here. And then you would move on to recommendation. What do you recommend as the nurse? What do you think is happening? I recommend this, or I would like to see this. Guys, in this section, it's 100% okay to say, I don't know. I don't know what's going on with this patient, but the patient is deteriorating quickly. It's okay to say you don't know. There is strength in saying you don't know, right? It's easy, as a new grad especially, it's easy to get caught up in this idea that you're supposed to have it all figured out, you're supposed to know. But we are humans. As a new grad, you are learning. So it's okay to say, I don't know, and throw the ball back to that provider and see what they would like to do. So after you say what you would like to have ordered, the doctor might tell you what they're going to order. They might give you a new set of orders, they might give you parameters. And in this section as well, this is where you can ask questions like, well, when can I expect a call back? Or when will you come and see the patient? Or when should I call you? What should happen that would make me call you again? This is where you list out those expectations. That would be under recommendations. And then under recommendations, you're going to go into repeat. So repeat, repeat, repeat. This is one of the most important parts of the call. You want to reiterate what the doctor said and confirm, especially if it's over the telephone. You could be working in a hospital setting, patient screaming, phone is ringing, there's a code blue going off on the PA system. It's hard to hear. So you want to make sure that you have repeated what the doctor has ordered and there's no room for error. You don't want to be in a situation where the doctor has ordered morphine and you heard hydromorphone and then you write an order and you give the patient the wrong drug. So it's really, really important to repeat, repeat, repeat. So starting from the beginning, identify, situation, background, assessment, recommendation, repeat, ISBARR. When you call the doctor and you use this framework, it's going to be your best friend. You'll be able to cover all your bases and it'll just help to paint a clear and concise, efficient picture of your patient. When it's 3 o'clock in the morning, last thing you want to be doing is flipping through charts and the doctor's asking you questions and you're kind of like, oh, sorry, hold on. But if you have all of your information ready to go in this format, it's quick. It's quick and it's effective. So after going through ISBARR, I'm going to tie it back to a real life situation. This happened to me when I was a new grad. So it was maybe around 3 o'clock in the morning. I had a patient, pulled on their catheter. There was blood in the line. So I knew that I had to call the doctor to tend to that blood in the line. Of course, I tended to my patient first. I did my assessments. I took my vitals. I gathered all of my information. And guys, don't be afraid to take out a piece of paper and write ISBARR and fill in each section. Don't be afraid to do that, because when you're on the phone with this doctor, you can literally just read what you had written down, and it makes it so much easier than having to go off the top of your head, especially on a night shift when, night shifts are hard enough. So don't be afraid to write out what you need to write out. Have the patient's chart open, have any relevant lab results open so that you can give that information quickly when it's asked. So starting from the top, I identified myself. My name is Jane and I'm calling from 6C on the acute medicine unit. I'm calling in regards to Mr. John Smith. That's identified. So what's the situation? I'm calling because Mr. Smith has pulled on his Foley catheter and now there is hematuria. There's blood in his urine. There's hematuria in his catheter line. That is the situation. So what's the background? So I told the doctor, Mr. Smith is an 89-year-old man who came to the hospital from home with his wife following a UTI. So he was hospitalized for this, treated with a course of antibiotics, but it was found that he was retaining urine. So a Foley catheter was inserted on this day, and it was left in for 2 weeks. The doctors decided to do a trial avoid, remove the Foley. However, it was found that the patient was retaining urine after 2 days of in and out catheterizations. So I included that information because the doctor needs to know that this patient is in for a UTI, when did they come in, and what happened while they were in the hospital. It's important for the doctor to know that the patient was retaining urine. We put in a Foley catheter. We took it out to see if they'd be able to pee on their own, and they were unsuccessful. So as I'm speaking, the doctor is able to paint a picture and think, what's going on with this patient, right? I also included that this patient has no known allergies. I also included that this patient has a history of atrial fibrillation and is being treated with apixaban. Why did I feel the need to include apixaban? Apixaban is going to thin your blood. So we know that there has been some type of internal injury. That's why there's blood in the catheter. Because the patient has been on apixaban for X amount of years, they're not going to clot as easily as you or I would. So they are at a higher risk of internal bleeding out, right? So it was important for me to include that this patient is on apixaban and they take that every day at 8 o'clock in the morning. And lastly, I also included that this patient has a history of dementia because that would speak to why this patient was pulling on their catheter. That is my background. Assessment. I did my assessment. I took my vitals. I checked the patient's genitals. I checked their penis. Was there any injury that was noted to the outside of their penis? So I told the doctor, at present, patient's vitals are stable for his baseline, and they are as follows. The patient is denying any pain. There's no noticeable injuries to the penis or surrounding area. Patient is ambulating well. Patient is communicating well. They are alert-oriented ×3. I just spoke to what I saw and what I assessed with my own 2 eyes. And then after that, I moved into recommendations. So I thought, well, what would I like to see this doctor order? I would like the doctor to flush the Foley catheter with 60 cc's of normal saline every 3 hours, PRN as needed, until the Foley is clear. I also added that if bleeding should persist by 7:30, again, this was on night shift, so I added that if bleeding should persist by 7:30 a.m., I would like to hold their morning dose of apixaban, the blood thinner, and have the most responsible physician, because usually when you're calling a doctor in the middle of the night, it's not going to be the most responsible physician. Sometimes it is, but a lot of times it's not. So I wanted to hold that morning apixaban and have the most responsible physician reassess that drug in the morning. And then lastly, I wanted an order for blood work, specifically CBC, so complete blood count, and KEB7, their electrolytes. This would just paint a picture on what was going on the inside of Mr. Smith's body. Should that bleeding continue, then we would be able to see like, whoa, their hemoglobin is dropping, or their electrolytes are out of whack, right? So that would just help us paint a better picture of what was going on. So after I listed my recommendations, the doctor actually okayed it. He said, you know what, that sounds amazing. I'm okay with that. So what did I do? I repeated myself. I confirmed that order. So, okay, just to confirm, I am flushing the Foley catheter with 60 cc's normal saline every 3 hours as needed until clear. If bleeding should persist, I'm holding that morning apixaban and having the most responsible physician reassess. I'm also ordering blood work for CBC and Chem7. And he said, that's perfect, that's great, thanks for the call. And yeah, I left that call feeling so good about myself. I was so scared in the beginning, but after I did it, I thought, okay, well, that wasn't that bad. And then as I moved through my career, I did it more and more and more. And with anything in life, the more you do it, the easier it gets. But I will recommend that you use this framework when you're communicating with anybody of the healthcare team because it just makes things easier. So that's it for my video, guys. Thank you so much for watching. I want to know, what do you use to communicate with members of your healthcare team? Do you use ISBARR as well? Are you using something different? Do you have any funny stories when calling doctors? That's always a good time. Comment below. And again, like, subscribe, and hit the notification. And I will see you in the next video. Bye, guys.